Hello, everyone. In this lecture, we're going to talk about the GI and liver disorders. Let me start by a brief introduction regarding the physiology and the function of the gut. So the function of the gut is a tube through which food is transmitted and processed and digested and absorbed. And it's all about chemical and mechanical events. So the GI or the gut is all about motility and chemistry. And the motility is stimulated by the parasympathetic system through its neurotransmitter acetylcholine, and also the intestines has kind of a local nervous system known as the myenteric nervous plexus, and it is serotonin operated. Also, parasympathetic stimulation increases all secretions of the gut, the gastric acid, and the intestinal enzymes. So as I mentioned, the parasympathetic nervous system increases gut motility and secretions. And therefore, because the neurotransmitter is acetylcholine, in pharmacology, you will know that one treatment of intestinal colics is to give anticholinergic drugs, because when you inhibit acetylcholine by anticholinergic drugs, you are going to inhibit intestinal motility, and this treats colic, for example. And there is the enteric nervous system located in the intestines, myenteric plexus, and serotonin is the neurotransmitter there, and it also stimulates the movements of the intestines. Some hormones also control the function of the GI tract. I want to talk here about cholecystokinin. Chol in Latin means bile. Cyst means a cyst. So cholecysto, that's the gallbladder. Kinin, it's the mover of the gallbladder. This hormone is secreted by jejunum in response to fat, not any type of food. So if you eat carbs only, if you eat proteins only, cholecystokinin will not be released. But if you eat a fatty meal, cholecystokinin will be released and will do two things. It stimulates pancreatic secretions that include lipase, which digests fat, and it stimulates gallbladder contraction in order to eject the bile stored in the gallbladder, because bile has an important role in fat digestion, which is emulsification of fat. And therefore, patients who have stone in the gallbladder, gallstones, if there is a stone in the gallbladder, these patients develop severe pain, which is described as biliary colic, only when they eat a fatty meal, because this is the only type of meal that releases cholecystokinin, which stimulates bladder contractility. And imagine when the gallbladder contracts with a stone inside, this should be painful. Some manifestations of GI disorders, dysphagia, which is difficulty in swallowing, can occur due to lesions at any level of the esophagus, and dysphagia is significantly serious if it is associated with blood in stools and loss of weight, and this means this could suggest esophageal cancer. Heartburn happens because of the reflux of acidic gastric contents into esophagus, causing spasms of the esophageal muscles. Esophageal pain usually is retrosternal, central, and it resembles pretty much angina. Abdominal pain in general can be classified into visceral, which comes from internal organs, and visceral pain is usually diffuse, poorly localized, and somatic, which is sharp, intense, well localized, and it comes from more superficial areas. Like, for example, appendicitis. At the beginning of appendicitis, because the inflammation is in the appendix, which is one of the abdominal viscera, the pain is poorly localized and patients feel the pain diffusely all over the abdomen. And then as the inflammation progresses and starts to involve the anterior peritoneum, the pain becomes very sharp, intense, and very well localized to the right iliac fossa. Also, depending on the location of pain, we can suspect what is the source of this pain, like upper abdominal or epigastric pain. If it is acute, this suggests pancreatitis, gastritis, sometimes even myocardial infarction presents as acute epigastric pain. If the epigastric pain is chronic, which means pain lasting more than 3 months, these are the causes of chronic epigastric pain: gastroesophageal reflux disease, chronic gastritis, peptic ulcer, and non-ulcer dyspepsia, as we're going to discuss in a few minutes. Mid or lower abdominal pain or discomfort. If it is acute, this could be due to intestinal obstruction, bowel infarction. If it is chronic, it's either inflammatory bowel disease or irritable bowel syndrome. Vomiting results from stimulation of the vomiting center in the medulla by many sources. The gut is one of the sources that stimulate the vomiting centers. And one of two things should happen in the gut in order to send impulse to stimulate the vomiting center: either irritation of the mucosal lining of the gut by bad food or bug, or distension. So gut distension or gut inflammation or irritation are among the causes of nausea and vomiting. I leave this GI gas for you to read. Constipation means small, infrequent, or difficult bowel movements. And among the causes of constipation, low fiber diet, lack of exercise, and dehydration, aging. Some pathologic conditions can alter motility. And one of the common diseases that can cause constipation, like hypothyroidism and also diabetes, because in diabetes you have autonomic neuropathy, so you do not feel that your colon is distended, and you ignore this distension of colon, and this results in constipation. Some drugs also can cause constipation, like calcium channel blockers and some antacids, especially those that contain calcium or aluminum. Diarrhea, which is increased frequency and fluidity of bowel movements. If it is acute, it could be due to infection. If it is chronic, it could be irritable bowel syndrome or inflammatory bowel disease. Okay, now we're going to talk about some disorders of the GI tract. And we will start with the upper GI disorders. By upper GI, I mean the esophagus and the stomach. By upper GI, I mean the esophagus and the stomach. Let's look into this mini case study. A 43-year-old heavy smoker male presents with chronic epigastric pain. There shouldn't be an A here. Sorry about that. Chronic epigastric pain, which means epigastric pain for more than 3 months. He also drinks 3 to 5 cups of alcohol daily. What is the most common cause of chronic epigastric pain? Here in this list, all these causes are causes of chronic epigastric pain. GERD, gastric ulcer, duodenal ulcer, both together are known as peptic ulcer disease. So GERD, peptic ulcer disease, gastritis, and non-ulcer dyspepsia. All these are causes of chronic epigastric pain. What is the most common one of these causes? The answer is non-ulcer dyspepsia. What's non-ulcer dyspepsia? It's an exclusion diagnosis. It's chronic epigastric pain that is not caused by GERD, that is not caused by peptic ulcer disease, and not caused by gastritis. So if you exclude all these causes, if you exclude GERD, if you exclude peptic ulcer, if you exclude gastritis, and you're 100% sure that none of these are causes of the chronic epigastric pain the patient has, then the diagnosis will be non-ulcer dyspepsia. Let's start with gastroesophageal reflux disease, or GERD, a very common cause of chronic epigastric pain. Before talking about the manifestations, let's just talk a little bit about the pathophysiology of it. So in the junction between the lower end of the esophagus and the stomach, we have a sphincter known as the lower esophageal sphincter. This lower esophageal sphincter prevents the reflux of the gastric acid and the gastric contents back to the esophagus. And actually, the mucosa of the stomach is well prepared to tolerate the acid, but the mucosa lining of the esophagus is not that well prepared for that. So when the acid regurgitates because a leaky, weaky LES, then wherever the acid goes, problems happen. And what can increase the risk of this regurgitation is when the patient is supine. Because when the patient is supine, then the effect of gravity, or the benefit of gravity keeping the gastric acid inside the stomach, is lost. And it's much easier now for the acid to regurgitate. And that's why most of the manifestations of GERD occur and intensify at night. So what are these manifestations? Remember, the key to symptomatology of GERD is wherever the acid goes, wherever the gastric acid goes, problems happen. So when it goes just at the lower end of the esophagus, it causes epigastric pain and also causes heartburn. And as it goes up, it causes substernal chest pain with heartburn. Other symptoms: sore throat when the acid irritates the pharynx. This causes sore throat. Metallic or bitter taste when the acid hits the back of the tongue. Hoarseness when the acid causes chronic irritation of the larynx. Chronic cough. And actually, GERD is the most common non-pulmonary cause of cough. And sometimes it happens at night when you eat a fatty meal that causes the sphincter to be even weaker, and you go right away to sleep. This acid regurgitates and it can trickle down the trachea and it irritates the carina, and the patient will wake up with severe irritative cough. And also the acid, as it trickles down, it can irritate the bronchi to cause bronchoconstriction and wheezes. So wherever the acid goes, problems happen. Diagnosis of GERD is actually by treating it. So proton pump inhibitors are effective in 90 to 95% of cases, which means if you give PPI, like drugs like omeprazole or pantoprazole, and the cause of the chronic epigastric pain is GERD, 95% of patients should improve. And in this way, you have just diagnosed and treated GERD at the same time. What if the patient does not improve, or what if you're not sure about the diagnosis? We can do the 24-hour esophageal pH monitor only if there is no response to PPI and the diagnosis is not clear. Do we need to do endoscopy for patients with symptoms of GERD? Only if we had some red flags, some alarming symptoms. Could it be cancer? Could it be something worse than GERD? And what are these red flags? Weight loss, dysphagia, anemia, blood in stool. and therefore we need to do upper GI endoscopy to exclude esophageal cancer. The treatment of GERD depends first on lifestyle modification. It's all about preventing the regurgitation of acid. And this could be achieved by elevation of the head of the bed. And here, elevation of the head of the bed is not equal to putting more pillows, because when you put more pillows, this will only result in neck flexion. So maybe you're going to have neck pain in addition to your epigastric pain. But elevation of the head of the bed by putting blocks, wood blocks under the head of the bed. So the bed looks like that. And you just put here wood block like 10 to 12 inch wood block here. And by this, you're going to make use of gravity to keep the gastric acid lower down and prevents its now upward regurgitation back into the esophagus. And try to be away from all things that decrease the tone of the lower esophageal sphincter. Smoking makes the sphincter weaker. Quit smoking. Alcohol makes the sphincter, relaxes the sphincter. Caffeine relaxes the sphincter. Chocolate relaxes the sphincter. Peppermint relaxes the sphincter. And fatty meals relax the sphincter. And a very important advice is no eating within 3 hours of going to sleep. Separate going to bed from the last meal by at least 3 hours. So these lifestyle modifications are even more important than pharmacologic treatment. And the pharmacologic treatment of GERD is very simple. It's only PPIs, proton pump inhibitors, omeprazole, pantoprazole. That's it, just one drug, PPI. If PPI fails, then we might want to do surgical narrowing or tightening of the lower esophageal sphincter, which is rarely needed. Okay, what if a patient with GERD, for some reason, you tested them for H. pylori, Helicobacter pylori, and it was positive? Treat H. pylori, give antibiotics to get rid of H. pylori or not? The answer is don't treat Helicobacter pylori if the diagnosis was only GERD, because H. pylori has nothing to do with the pathophysiology of GERD. It's all mechanical. It's all mechanical. So there is no need to give antibiotics for GERD, even if the patient tests positive. There is even no need to test for H. pylori. If you're sure of the diagnosis, no need to test for H. pylori. Coming to another lesion, that disorder that gives manifestations similar to GERD, is the hiatal hernia. Hiatal hernia is a defect in the diaphragm, allowing portion of the stomach to pass through the diaphragmatic opening into the thorax, like herniation. The risk increases with age. Women are more affected than men. Predisposing factors can be increased intra-abdominal pressure like obesity or ascites, pregnancy, chronic straining or coughing, and the clinical manifestations are similar to GERD. In addition to that, usually these patients might suffer from kind of difficulty breathing after eating a big meal, because this part of the stomach that herniates in the thorax becomes full, and sometimes it might be even incarcerated, which is rare, and this constitutes surgical emergency. Okay, I'm gonna end this segment here, and in the coming segment we're gonna continue with the gastric causes of epigastric pain.